I'm just going to, can we start the live stream?
Yeah.
Yeah. Okay. Good afternoon, everybody, and welcome to the Health and Wellbeing Overview and Scrutiny meeting of Tuesday the 15th of February. Welcome, everybody. The meeting is being live streamed and is available on the Council's website. So we'll start off with apologies for absence. I have apologies from Councillor Humphrey, Councillor Ferguson. That's it, I think, yes? Yeah? Okay. So no others from the floor. Okay. Minutes of the meeting, sorry, I have to take my glass off. Minutes of the meeting of the Health and Wellbeing Overview and Scrutiny Committee from the 4th of January have been circulated. Can they be confirmed as a true record for me to sign?
Agreed.
Agreed. Okay, thank you. Disclosure of members' interests. Do we have any disclosure by any members? No. Forward plan. We do have the forward plan. I can't see anything on it that's for our committee. Is that anybody any comments on that? No. Okay. 5. The Health and Wellbeing Board. We've got the minutes of the Health and Wellbeing Board that was held on the 9th of December 2021. Has anybody any issues? They come to scrutiny for us to note any issues. Is there any issues that anybody feels we should be looking at? No? Okay. The Kovid Equality Impact Assessment is going to the Health and Wellbeing Board regularly, so we'll be able to see the updates on that through there. That takes us to number 6 on our agenda, which is the access to GP services. And we have a presentation from the CCG and Dr. Graham Sayers and Dr. Robin Hudson. So can we just ask you to present your report? Thank you.
Good afternoon, everybody. Thank you for asking us to come. I'm sorry we couldn't make it. I think it was 3 weeks ago when we had to postpone due to COVID staffing crisis. So we've made it finally. I'm Graham Sayers. I'm Clinical Chair of Northumberland Commissioning Group, and I'm a GP at Annick Medical Group. I've been there as a partner for approximately 20 years now. And with me is...
Yes, hello, I'm Dr. Robin Hudson. I'm Medical Director at Northumberland CCG, and I oversee general practice as clinical lead, and I'm a GP in Northumberland as well.
So I'm going to do the first part of the presentation, and then Robin's going to talk a little bit about the engagement element on one of the last slides. This afternoon, I would like us to just try and put into context why we're having this discussion a little bit as well. So my slides are going to take us through a number of different aspects of what access to primary care might mean, what some of the challenges are, and what the CCG and what is happening to try and improve that situation. I apologise, I may not be able to see this print on this end. I'll do my very best. This is an actress. It's not one of my patients, but it could be one of our patients in Northumberland. And essentially she's saying, I can't get an appointment with my GP, which is really what a lot of people consider access to be. But behind that statement can be a whole number of reasons why that person is voicing that statement. So if we have a think about what that might mean, might be that you can't get through on the phones. We hear that a lot. It's just the engaged tone. I can't get through on the phone. It might be that I can get through, but I've been told that actually the practice is only dealing with urgent problems today. It might be that actually I can get through, but actually what I'm being offered doesn't suit me. It could be that the way that I'm being asked to book my appointment doesn't really fit with how I would like. So I'm being asked to try and use an online system, or I'm being asked to try to book something with something called e-consult. I want to be able to use the phone. So that can often mean one of a number of different things to different people. An appointment may be a different thing to different people as well. So is that a face-to-face? I think that some of our patients feel that they should be able to book an appointment face-to-face, and that might be quite a reasonable request. It might be that they find using the telephone difficult. People like to think of having a GP. I know that I have patients in ANIC, and I've been their GP for 20 years, and I am most certainly their GP. It may be that they're being offered appointments with other members of a primary healthcare team, which on the surface may be entirely appropriate in terms of their needs, but it is not their GP, and they like the familiarity and they have a trusting relationship, and therefore it's a level of problem for the patient if they can't get what they feel they need. We also then have this idea about, why am I being asked questions by the receptionist that only the doctor needs to know? This is often now a case of trying to get people to the right person first. So if we have a multitude of different possibilities for solving that patient's problems in-house, it's useful to know what the problem is so that we can be as efficient as we can. It might be that that leads to a level of disappointment, that it is not a GP who is going to solve my problem. It may be that people have a bit of a laissez-faire attitude, that, you know, they're so busy, if I don't make my appointment, it doesn't really matter, somebody else would take it. And then there's also this attitude sometimes around, which is quite reasonable, I think I do have a need, I'm willing to wait a few weeks just in case I do have that need still by then. So people book a long way in advance when they think they may have a need, and actually it may not be. So that on the surface of that, I can't get an appointment, it often means multiple different things to different people. And that's not a challenge, that's just, I'm just describing a current situation. You know, that's how it is really. Why do things have to change? I think change is difficult for us all. Humans are creatures of habit. I would challenge you to say that you probably all sleep on the same side of the bed every time, and you all get out of the same side of the bed in the morning. And these things are what we do by habit. And when we are under stress, I think we find change more difficult. And often when people contact a GP surgery, it's a time of stress. And if you contact that surgery and their system has changed, or you're trying to navigate a system which is different, that's an extra layer of stress which adds to your problem. And let's not forget that the pandemic over the last couple of years has certainly increased our levels of anxiety in general and made life more difficult. So change is difficult for us. In the world of the CCG, we tend to call it transformation of primary care services. That would suggest to me that this is a way of gradually changing things in a positive way, rather than changing things and it's always going to be bad because it's a change. Okay. This equation is really just to try and explain. The red would suggest poorer access. Okay. What's the increased demand? When we talk about increased demand in primary care, what are we actually talking about? And there are many factors which lead to this. You could argue it from a perspective of, we actually have a lot more older people living in Northumberland than we would have had 20 years ago, and their needs are actually different in terms of the population from that time frame. We also have more medical interventions than we ever had. We have more drugs that we can prescribe. We have more ways of trying to make people live longer. We control people's blood pressures. We use cholesterol lowering drugs. There are many things now that we are trying to do better than we were before, but this all means interventions with people, talking to people. Increased demand is also coming our way from hospitals. So there is a piece of work at the minute to try to reduce the need to people to attend outpatient appointments. It's called patient-initiated follow-up in outpatients, which is a piece of work coming. But actually, if there are less follow-up appointments in secondary care, where would these people go if they need help? And actually, we are being passed much more work these days from the hospitals than we used to do. And that's good. It's better to keep people looked after closer to home. Increased demand might mean actually the way that our culture works these days. It may be that people actually want their solutions now. I may be making a false assumption that that's the younger generation. However, if you can buy what you want on Amazon in the next 5 minutes and have it delivered by lunchtime, how you access healthcare you may perceive would be different from how somebody else might do who doesn't use technology to the same degree. So these are all increased demand. There's other hidden demand in there as well. So, for example, the gun licensing laws changed recently. And in Northumberland, we have a lot of gun holders, and they're having to reapply for their licenses. And that actually is work that comes to the GPs, because we have to check notes and go through that. And that's not anything that we've had to deal with before. It's just more work, because that's where it sits. Reduced capacity. Going back a number of years, there was a plan to increase the number of GP whole-time equivalent. And I think the plan was first around 5 years ago. And actually, the number of whole-time equivalent for GPs has remained static. So despite the increase in workload, the difficulty we have is that we have exactly the same number of GPs working. So we haven't actually, in my eyes, got a reduced number of GPs to what we have, but we've got about the same. There are other things which I'll come to, which is to increase our workforce. If you add those two things together, people will find it harder to access primary healthcare. Perhaps. Transformation, and I apologise, this is where my eyes start to struggle a bit, but these are the boxes that are worth thinking about. So how are we building capacity, and how as a CCG are we doing that? Well, we're trying to recruit and retain a wider team. So we have things going on in Northumberland where people come off GP training schemes, and we try to encourage them to remain in our patch by creating posts where they can do extra training, have peer support, and if you can keep people in your patch as they finish their GP training, they're more likely to stay permanently. When we talk about the wider team, this is actually the type of healthcare practitioners such as physiotherapists, pharmacists, advanced nurse practitioners. There's a whole wealth of new professionals who you might come across in your GP surgery who can provide the type of care which a traditional GP would previously have done. Working at scale across practices. There's a whole box on here on the left called the primary care networks. But there are ways of trying to get GP surgeries to work together now where we have members of staff who are employed on the part of the PCNs, but actually work into multiple different surgeries. So examples of this again would be the pharmacists. One of the most successful ones has been the GP link workers. Now these practitioners are actually very good at understanding all of the support mechanisms which are going on in a community. And often, I think there was a piece in the paper yesterday talking about how isolation should be considered as a public health problem. And there are many of our patients who present with health problems to primary care, and actually a lot of their issues fall into the socially isolated bracket, which is why they're presenting to us. So if we can get them plugged into networks to get them more supported, we can reduce the burden on the health system. I've done the box on the left for the primary care networks. It's important on language and terminology in the bottom corner. We do have many different terms for doctors. We have GP partners who work, we have salaried GPs, we have training GPs, we have locums. The system is changing perhaps. Your traditional idea of a GP partner who has worked for 20 years like myself, and perhaps in the past their sole job was being a GP, much more frequently now we have GPs who actually want to work several days in general practice and several days doing something else. Now both Dr. Hudson and I actually are in health leadership roles as well as doing our GP jobs, but we have other GPs who work in dermatology part of the week, we have other GPs who work in palliative care part of the week, and this is thought to be a good thing largely because it keeps interest, it reduces burnout in GPs. But actually people often don't understand why their GP isn't in the surgery all the time. And this has implications for continuity, which I'll come to. So if you don't have access to the same team of doctors every day of the week, sometimes you have a need and it can't be your GP who's looking after you that day. Also in the language side of things, community services, neighbourhood teams. When I talk about general practice, actually, I think we should start talking about the primary healthcare team and primary healthcare services as a whole. So this takes into account the teams such as the community nurses, traditionally known as the district nurses, It talks about your health visitor team, your midwifery team, all of those people who work into a community. And I think that there are ways forming now where those people can be much more part of a wider team rather than a GP working in isolation. And I think that's really important, that we avoid pockets of isolation. I've mentioned the social prescribers, which are in the bottom left. What have we learned from COVID? I think we had to adapt and change very quickly during COVID. And this was a challenge because we had people under stress, we had a changed way of contacting surgeries. A lot of surgeries moved to very much remote way of working, where you would get telephone advice, we might use pictures, we might use videos. Interestingly, the video system came in very quickly in COVID, and I think many practices have moved away from using videos as a form of consultation. Being able to transfer pictures very quickly is really useful. You can save the planet by reducing travel, by seeing rashes and things on the skin without people needing to travel. But most of what we can do is actually done over the phone on the whole, and then on the whole, practices will always offer face-to-face if people need it. Some practices are running a system where you can book a direct face-to-face if a patient needs. Other practices at present are actually filtering everything on the phone and then coming to an agreement with the patient whether they need to be seen face-to-face or not. Communication systems, email, text messaging, getting things out to patients has become much easier with the advent of mobile phones and the systems that allow us to text people. For example, I can do a fit note and I can text that to somebody. They don't have to travel to the practice to pick it up. We don't have to put anything in the post. Things are much more efficient in that sense. Being more efficient in the bottom right hand side. So I've touched on technology. Care navigation is an interesting one. So there are some practices in Northumberland now have their kind of frontline contact with the patient. They call their care navigation or their hub. And they try very hard to work with the patient to find the solution right at the beginning. And these are receptionists largely who've been trained to a higher degree to be able to try and solve some of the problems at the point of contact. Making every contact count, I was trying to think of a good example of that. And I think, for example, if you fill in an e-consult in our practice, it will automatically ask you if you smoke or not. If you do smoke, you will automatically be sent the details of the smoking cessation service, irrespective of anything else that happens in that interaction. So there are lots of ways of trying to just make the technology improve the health of the population. I'm on my clicker, not the computer in front of me. I think it's always good to challenge what the underlying principles are behind what we are trying to do in transforming services in primary care, though. And it's very much about the partnership working and working across health and social care and trying to make sure that we are all complementing what's happening. The continuity of care issue is so important. We know from studies that if you do have regular contacts with the same person, there is evidence that your health outcomes will be better. Referral rates are lower, people have better health. Now, obviously, that is a challenge in wider teams. So there is something about how those teams develop, and there is work being done about teams within teams. So if you are a very large surgery, maybe there is a way of reducing the number of people available to you, either by your geography within the patch, so that you are dealt with by a slightly smaller team, and you're less likely to get offered too many options. I think it sometimes becomes too confusing. There is definitely something about the value of the relationship between a practitioner and a patient. It has to work on trust, and we have to avoid polarizing our views about not being able to access services. I think in primary care, when it's under pressure, there is a danger that you become entrenched. Certainly, our receptionists can find it a real challenge. And sometimes what can happen is you start working at odds with each other rather than working in partnership with patients about how best to use the services. And that really is something that is really important, and Robin will come to that a little bit in a minute. With any of our new systems, we always have to think, am I, without realising it, making it more difficult for somebody here? And that's a challenge, really. So do we discriminate against our older people by creating more technological ways of getting in touch with us? Do our people who are hard of hearing have more difficulties? Do people from ethnic minority groups have more difficulty in some of the systems that get put in place? And I think it's always very important to challenge that and say, well, hang on, have you considered everybody's needs in this equation? I've mentioned including the residents on the journey, and I think trying to be proactive and anticipatory around our healthcare is really important. When the chips are down and the shutters go up and it says we can only deal with urgents today, that really is just about trying to make sure that we're being reactive to the needs of the day. What we really need to be doing is trying to find the time and the headroom to say, but what might be the needs of 2 weeks' time or 3 weeks or 10 years even, and what can we do now in primary care to try and make that a better outcome? So finding headroom is really important and being proactive. Robin, over to you.
Yes, thanks, Graham. Just to give you a little bit in close, really, just to explain to you that as a CCG, we're in a situation where nationally during the COVID-19 pandemic, practices were mandated to take on full telephone triage. We are now emerging, I hope, from that pandemic. That the main issue with that mandate was that it was never really evaluated what patients thought about that. We certainly have received that there's been a lot of negativity, certainly in the media, regarding access to a face-to-face GP. So as a CCG, our answer to that is, well, okay, let's ask our population and let's ask our practices what they think at this point in time. So we were awarded some funding as a CCG, and we decided to develop a bespoke project, which is running now, to develop a local engagement program, asking our residents what they think about the current state of affairs, and particularly over these new tools, new ways of access that has impacted on the care. We're asking practices as well what they think, and then we're also going to develop a local action plan to see how we can look at this experience and see how we can move general practice forward in a way that's meaningful for residents. We are also in the midst of supporting practices as they struggle to recover from the pandemic in terms of workload and all the infection control issues and staffing absences. And ultimately, we hope that what we find from our piece of work will inform us for the future about how we truly engage with the residents in Northumberland. So with the help of Explain, Market Research and Health Watch, we have commissioned them to design and deliver an engagement survey with practices and with patients. So the survey was 500 face-to-face on-the-street surveys. We have an online survey and paper survey available, 24 in-depth interviews, an online survey for practices, outreach surveys and focus groups delivered via the voluntary sector. And our progress to date, our engagement period finishes on the 25th of February, so this month. We've almost completed 500 surveys. The focus groups are almost fully recruited and booked. And our online survey has already received 2,000 responses. So where do we go with that? Well, ultimately, we hope that we'll have a finalised report by the end of March, which we will then be happy to present to to members of this committee. And in terms of what is that going to mean? Well, we're going to feed that back to you. We'll also feed that back to practices as they look forward to see how they can adapt their access services in a way that's meaningful and useful for their patients. So really that was all I wanted to say. So finally to Graham.
Back on. So what we want to try and do is get to a place where our patients and residents are actually saying, how can I get the help I need? Not, I can't get an appointment, you know. But it's a journey. There's lots of transformation from where we are now to getting to that point, I'm sure. And really, it was an ask of all of our partners around Northumberland to help us get to that point as well. So when there is feedback from residents that things are not as good as they could be, what I would always ask is, try and understand, try and come to us, try not to polarise the view and say, yes, I agree, it's terrible. It's more, well, let's try and understand what that might be and what we can do about it. Happy to take questions. Thank you.
Thank you. Right, I'm going to take questions. Can I just say, though, that I think we should really look at in general, not at local issues. I'm not sure whether our two guests would be able to answer specific cases, but I'm sure you all understand that. So I'm not sure which of you had your hand up first. Was it Richard? Yeah.
Happy to go first. Two things. I mean, the perception is that we're having trouble now, but the system wasn't perfect pre-pandemic. You know, it was always tricky to get an appointment. So we're not starting with it was fantastic. I think there's something on Facebook that says it takes 9 years to train as a doctor and 2 minutes to train as a receptionist. And one thinks it's a doctor and one's not. So I think the triage that you've got coming via receptionists might be a little bit creaky, because obviously people either don't want to say what's the matter with them or whatever. But I think, and I understand the triage that you've got to try and find the right peg for the right hole where it goes. And I think that will be a problem for some. So the start, you said lots of things about why people didn't feel whatever because it didn't fit and didn't all that. There's a lot of society do not want to go to the doctor at all. Mainly men, oh, it'll get better or whatever. They don't want to go. So, I think what you've got may be improvement, but sometimes technology, you pick up the phone and you dial Ponteland and you're fifth in the queue and you think, half an hour later or whatever it is. It might not be like that, but it feels like that. And you think, you're number one in the queue. And you think, the conversation in front of me's lasted 10 minutes. What are they talking about? And that's just personal. And the other thing that you mentioned was gun certificates, because this is streamed live. I've got a gun certificate, a shotgun certificate, and I haven't been told anything, because there's two types of gun certificates, just for clarity. There's firearms certificates, which I presume is what is going to need extra attention, which is for rifles, whereas shotgun certificates are different. Just for clarity, because there could be a lot of confusion going out there if it's not the right certificate that needs further. Thank you.
Thank you for the clarification on the certificates for the guns. The process has changed. I'm not an expert in which bits of that, but as GPs, we're expected to do more paperwork just now for the ones that are coming to us. So try and avoid confusion there. Yeah, I agree with that. I'm not sure if any of the other bit was a question or if you just wanted to feedback.
It's changed. The pandemic has changed things, and there's, go online, do this, do that, and the face-to-face that has pre-pandemic has changed slightly, and that's probably what the problem is. And I don't know how you get over that, because the pandemic will have brought in some fantastic opportunities to change the workload for the better, but unfortunately the older population do not do internet the way that some of us try to, and I think that's here.
Okay, so I think on that point it's really important. It goes back to my point about trying not to discriminate against certain groups and try and satisfy everybody's needs, so that the way that the systems are developed, taking into account the feedback that we get, I think we'll need to make sure that we're doing our best for everybody that needs. I think the question or the point about triage by receptionists, I also want it to be kind of very clear that we are not proposing that every patient should be asked everything about their health problem by a receptionist. It's all about being efficient at that point of contact to get them into the right place as quickly as possible. There is obviously an issue to do with the longer you take with an individual on a phone line. If there is a challenge on phone lines, other people will have to wait longer. And that also brings into account these other methods of getting the information that we need from people that other people may be able to use more efficiently, such as one version is called an e-consult system. Thank you. Robin, did you have anything else you wanted to say on that?
I think just a point of clarity as well. I think regarding receptionists, I mean, I know it's probably an anecdotal comment about 2 minutes to train a receptionist, but the receptionists are actually trained extensively in terms of, number one, is actually urgent problems. So we do have, on occasion, patients ringing up with central chest pain, indicating a heart attack, and actually to not direct them to 999 would be, well, this is really important that individuals like that are directed appropriately and not waiting for a GP who may or may not be able to see that or deal with that immediately. And I think healthcare has actually just become much more complicated. I think simple navigation, yes, receptionists have a role. I think most receptionists would say that if somebody rings up with complex issues, they will just say, right, we'll put you through to the doctor, or we'll put you onto the list for the doctor to speak to you. They won't try and work out what because I think they're very well aware that they're not medically trained. I think that's what I want to say.
It wasn't a criticism, it's just it's a perception.
Thank you. Councillor Hill?
Thank you. The problem I've got with the way you presented this is, I mean, we all know, and we could all go on for hours, examples we've had, and I won't, but about the problem getting access to health, to GP, somebody even to get hold of on the phone. I mean, it's like, you know, in the old days, you used to hear about people, I waited 8 hours on the phone to get a ticket to the Take That concert, you know, and I did, and I managed, I was on the phone for 8 hours, but I got through and I got my ticket. It was worth it. I mean, people just are struggling, and people not even getting to speak to GP. So this is a problem, but the approach you're taking is not, we know there's a problem of access to GPs. It will require lots of reform. It's obviously a government issue. You know, there's lots of reasons why that is. People need to, you know, be realistic about their expectations. There's that aspect too, but it's a big challenge and we have to deal with it. The attitude seems to be, oh, well, some people don't really need the GPs. They think they need an appointment, but they don't. And that is just the way it is. And I think it's not really very satisfactory. It would never happen in the private sector. And you know, the NHS costs £136 billion a year. And I think any resident, I'm not criticising you. I know you're sort of presenting, but it's just almost like it's an awful situation. There'll be people dying because they haven't been able to access, and they've got a serious condition that could be dealt with because they can't access a GP. But the attitude seems to be, well, that's the way it is, and some people might not need GP. And for me, that just is wholly unsatisfying. I'm not saying there's an easy solution to it, but the first way to tackle any problem is the recognition that it exists.
Okay. When I put these slides together, I was hoping to give a sense of the context of this. What I didn't come with is the details of the primary care strategy that sits behind us at the CCG, which has a plan to address many of the things which we've talked about today. So I didn't go heavy on detail on those parts, and perhaps that's a misjudgment on my part. I wasn't sure how much detail you would need from that perspective. Certainly, I don't want you to think that there's any complacency at the CCG about us trying to work with primary care and transform the services to get the best services we can for the people in Northumberland. That's a very significant aim that I think any of us that work in the primary care side would hold. I think I'm just going to ask for Robin to comment on that point as well, because I think he would probably be fairly horrified if he thought that we were giving an impression that we were being complacent about making changes for the better.
So just to clarify, you accept that premise, but what the point of your presentation is for us, what we communicate to residents, so messages like, think what you actually need, but you're not denying the overall premise that this is a serious problem, it needs to be addressed.
I think it's undeniable that there is a significant problem for some people getting through to GP surgeries, getting through on the phones. I hear it nearly every day that it is a difficulty for some of our residents. I also hear a patient in a public meeting last week, e-consult is fantastic. I can put it in from work in Newcastle. I was responded to within an hour. I got what I needed. So I also think there is an awful lot of good practice going on in Northumberland, and there are a lot of people getting their health needs met. So I think we do have to balance up some of the negative that we hear with an awful lot of hard work which is going on, and a significant attempt by practices to give people what they need. Because I think it would be very difficult if practices worked incredibly hard and then hear nothing but negative feedback on the services that they're trying to provide. Robin?
Yeah, thank you. I mean, I hope I can give a bit of an answer to your concern there. Number one is, so Northumberland looked at access back in 2015. We did a significant piece of engagement work through something called the Northumberland Vanguard programme, looking at access and how to increase access. And in fact, over 12 months, we increased access by 170,000 appointments. And that was published in the King's Fund. So just to say there's a CCG, access isn't just a COVID issue. It has been an issue for a while in terms of how to improve it. But I think the other aspect, maybe to reassure you, is sitting behind the presentation, there is a quality assurance process that is in existence where we monitor the quality of practices, and that covers cervical screening, baby immunisations, it covers early cancer diagnosis, A&E attendance rates. There is actually a huge list of things that we would monitor in terms of harms, because ultimately what we're thinking about is harm occurring to individuals, residents in this county. Well, during the COVID pandemic, we know there was harm occurring because of COVID-19. During that, though, practices were asked to focus on the most vulnerable residents during the pandemic, as well as to keep cervical screening going, keeping baby immunisations going, keeping early cancer focus as well. We're now emerging from that, but practices are still trying to catch up with the work that they had to suspend due to workload and due to, again, government mandate and guidance. So I would say that I think my take on the presentation is really to explain access is a complicated issue. How are we going to move it forward? Well, we're going to move it forward by asking residents what they think, at the same time as asking practices what they think, and coming up with some kind of, there isn't just one access model, that's the problem. They say actually that nationally there's about 6 different access models, and we have 37 practices doing a variety. Now, we can't mandate to them to have one access model, but we can certainly steer guidance to say, well, actually, our residents in Northumberland are saying this. We know you're saying this as practices. Why don't we unify and actually make it a much more unified way forward in terms of how practices manage their workload? But respectfully, I can't tell practices what to do because they're independent contractors. So I hope that, well, I hope that answers some of your questions.
Thank you. Did it? Yeah.
Yes, I understand where you're coming from now. I suppose my premise you agree with, and that's underlying. It's that I get what you're saying. There wasn't the complacency that I thought.
Thank you. Councillor Hunter?
Thank you, Chair. Again, similar to what other councillors have said, it's the access. You know, yes, the new online one, booking and phone backs, is handy for the younger generation because they can, if they need to speak to a doctor, they can book online and the doctor phones back and they can still go to work unless they're that ill that they can't go to work. But it is that access by phone, because we've got to remember there's still a lot of people don't use internet, don't use emails, don't have mobile phones, so the only way that they can contact is that. And sometimes, you know, 30, 40 phone calls in the morning to find, sorry, the last appointment's gone, try lunchtime, try again, and the same's gone again. You know, try 101, and so, surprisingly, the phone 101 to get a phone back for the surgery to say you can have an appointment at such and such a time, which gets frustrating to them. And I think it's trying to work as to taking it forward in the new format, but picking up everything else, because if they can't get appointments, oh well, I can't get an appointment with a doctor, I'll just go to the hospital because the local hospital will see me. So then that means that that doctor that's on duty and working in the hospital as well is still having to pick it up. So I think we've got to look at the model that picks up everybody and tries to get access, because otherwise people just complains.
Councillor Nesbitt?
Well, I'm pleased to see there is a consultation going out to the residents, because recently I've experienced a big problem with access to the GPs, not for me, but for my husband. 3 months he's been on antibiotics, kept giving him over the phone. Until Sunday, I decided to go online to try and get him in, to be told there's no appointments online at the moment from his doctors. And now yesterday I pleaded with a doctor to come out and see him. They finally did come out, and now he's in the hospital. So there's a big problem there with the access, and that's experiencing it myself. So I can understand where a lot of patients are coming from, because I've had to experience that. Now it's upsetting, it's frightening, and like I say, now he's in NZEC now. I'm going up there from here, but it is a big problem that we need to put right. And like I say, I'm so pleased there is a consultation going out. I don't like bringing my personal problems here, but unfortunately I've had to today to speak out, because I am experiencing that. Thank you.
Thank you. Do you want to comment at all on that? Or?
Yeah, just to say, I'm really sorry to hear that. We're definitely not complacent about this, as I've already said. And I hope I'm sorry he's in. I hope he makes a speedy recovery.
I think the committee would echo that, Councillor. Any other questions? You all right? Okay. Thank you.
Veronica, can I just come in there? I wasn't getting to the point of that. What I was trying to get over is the fact of the experience at first hand. So it wasn't about, sorry in that. It wasn't about that. I'm trying to get that message over, because this is not just happening to me. This could be happening to a lot of my residents, and that's where the problem lies. Thank you.
Thank you. I do have one point as well, just before we finish. And it's more about the triage. I think we're a rural county, as you know. A lot of our practices are rural, and a lot of our receptionists are residents in the local community. And you're probably nodding, so you know what I'm going to say. People don't always feel comfortable about telling their neighbours about their health issues, and I think that's a point we do need to be aware of as well.
I think it's a very good point, and the receptionists are always told that if a patient feels that they don't wish to share, that's okay. The receptionist may say, do you understand why I'm asking? And it may help, so there'll be a bit of an explanation about why they're asking, but we do train our receptionists to be sensitive to those kinds of issues as well.
And thank you very much for coming today. We do appreciate it. Appreciate you couldn't last time, but we missed you, and we're glad you've come today. Thank you very much. I believe you need to get off, which is... Yeah. We'll just wait a second to give them a chance to leave. Thank you. So our next item is the access to dental services, and we've got a presentation from NHS England Improvement, and we've got Pauline Fletcher, who's the dental commissioning lead, and Simon Taylor, who's the oh, I've lost that one. No.
Dental network from the Sunderland timing with you.
That'll do nicely, thank you.
Okay, good afternoon, and thank you for the invitation, and equally apologies we couldn't attend on the 1st of February. As Chair has said, I'm Pauline Fletcher. I'm the Senior Primary Care Manager for NHS England and NHS Improvement, and I have responsibility for the commissioning of primary care dental services across the whole of Cumbria and the North East. Simon is our local dental network chair for the Northumberland and Tyne and Wear area. And we're going to do a little bit of a double act today, if that's okay. I would just like to start by just giving some background and some context before we take you through what the current position looks like with regard to general dental access. I don't know whether you realise, but general dental practices work in and operate in a very highly regulated environment. So there is a lot of nationally prescribed rules, regulations, guidance that they have to comply with to ensure that patients are treated safely. I think it's really important that I say up front that general dental practices don't operate in the same way as general medical practices. So there is no such thing under the dental regulations as registration. I know you'll hear quite a lot about I'm registered with that practice. Practices tend to keep and maintain a cohort of patients. That has been a challenge through COVID, but there isn't any registration. So at any point, anyone can access dental care from any NHS practice that has a contract. So I really just wanted to make that clear up front. The way the dental regulations work is that we contract with dental practices who are independent businesses in their own right, and we contract with what's called units of dental activity, or you might hear them referred to as UDAs. Now, the utilisation of those units of dental activity will be determined by the presentation, the clinical presentation of the people who access the practice. So, for example, if you access your practice and you just get a routine checkup, that equates to 1 unit of dental activity. If you get a filling or extractions, it doesn't matter whether you get 1 filling or 1 extraction or 2 or 3, it's 3 units of dental activity. And more complex treatments like bridges, like crowns, that's 12 units of dental activity. So we commission a cohort of activity from practices across that sort of financial year. I think another thing I would like to just touch upon is NHS England doesn't commission private dental care, but the NHS regulations don't preclude our NHS dental practices from offering private dental care. But I think an important point to note is that where that is the case, the practices tend to have their own appointment books for NHS and separate appointment books for private care, and they have staff allocation. So whilst, depending on the demand that goes into the practice, they may not have an NHS appointment, it may be that they have capacity in the private part of their business. But no patient should feel that private dental care is their only option, because, as I say, there is no registration, and you can actually then contact another practice to try and access dental care from there. The NHS provision has to be available across a practice's contracted opening hours, but the demand for appointments can vary depending on the people who contact. So quite often, you know, it can vary days of the week, it can vary on the clinical presentation of the people accessing, and obviously the NHS practice will have set appointments, and depending on what is required and what comes through the door, the utilisation of those appointments, they may have to sort of double up. So I think that's some of the challenges around where you may be told, I'm really sorry, I can't offer you an appointment today, but this should obviously give you some options and give you self-care advice. In terms of what we have commissioned across Northumberland, we've got 42 dental practices across the patch, and we commission just over 568,000 units of dental activity. That's every year we commission that amount. In addition to the general dental practices, we also have a community dental service, and they look after the needs of patients with more complex medical problems, as well as some of the housebound patients. On the slide, you'll notice I've put in the 2019-20, which was the pre-COVID year. And on average, about 90% of those units of dental activity that we commission has been utilised. So there has been some unused capacity. But if I'm being absolutely honest, that unused capacity is not necessarily to do with the fact that there isn't the demand there. That could be due to other factors which we'll come on to later on in the presentation. I think in terms of two of the key areas that we probably want to touch upon is because of the rurality of Northumberland, a bit like general medical practice, recruitment and retention is an issue for us. It is an issue in terms of retaining the dental, not just for dentists, but also for dental nurses. It is a constant challenge for us. We hear a lot about our practices saying that, you know, they have a turnover of staff. We are working with Health Education England to try and see what we can do to address that, to retain the staff that we've got, but also to try and attract new people in. A bit like our general medical colleagues, I think the workforce is changing in terms of, we used to have dentists like Simon, I'm going to use him as an example, who was sort of NHS through and through. You know, he had his dental practice, he's worked in dental practice for years. The workforce that we're getting through now are very much wanting to work more part-time. They're wanting to do some specialisms. So I think workforce is a significant challenge and continues to be a significant challenge for access. The other key thing, which I'm going to hand over to Simon to explain a bit more, is obviously the COVID-19 pandemic has had a significant impact on access across the whole of the healthcare system. I think it's had a particularly significant impact in dentistry, and I'm going to hand over to Simon at this point to just explain a bit more around what the size of that challenge.
So I'm just Is that better? Great. Yeah, I'll just digress slightly from the slides because I'm sort of, the slides I was prepping for weren't these, so I'll just sort of talk generally if that's okay. So what issues have we faced in dentistry, and why are they different to general medical practice? Well, as you probably know, when you go and see your dentist, you get quite up close and personal with them. They're sitting that far from your mouth. As we well know, Covid is spread by respiratory droplets, so there's an issue there. Throughout the pandemic, dental practices, the staff have had to use different levels of personal protective equipment. Typically, when you see someone, we wear a type 2 face mask. This isn't type 2, but they look very similar to this, and we'll be sitting behind that. Throughout the pandemic, we've had to wear FFP3 masks, which are much higher filtration. You can wear those, but they're not effective unless they are fit tested. So you actually have to check that that particular mask on each of you fits. Now, one of the challenges initially was to protect staff, we have to ensure that those masks are correctly fitting. How do we do that? There are very few people who are fit test trained. It tends to be purely an industry. So we then had to go and create some courses, get fit test trainers in, and train people like myself to go out and fit test the practices. We found that what may fit Richard wouldn't fit his pal in front because you've got different shaped faces, and what fits me won't fit Pauline. So we had an issue with that. We had an issue with the supply of the protective equipment, because suddenly let's say Arco, who provide FFP3 masks, they had them purely for industry. Suddenly all the medical people wanted them as well. So there was a big drop in the supply chain, massive issues there. Initially, dental practice around about March 2020 were told we had to shut. We had to shut and only provide what they called AAA, which is advice, analgesic necessary, antibiotics. To support that, we had a spine of urgent dental care practices where patients who could not be deferred until the infection rates in the pandemic had reduced, could be referred to. So we had quite a lot of patients who had minor problems that in normal circumstances would be dealt with that had to be deferred and deflected. Any patient who was seen once practices reopened for face-to-face treatment, which is around about July 2020, and required what we called an aerosol generating procedure. That is, for those of you who don't know what that is, that's the whistly drill. When you go to the dental practice and you hear the whistle and there's water squirting around and the nurse has the hoover, that creates an aerosol. COVID is spread by droplet infection, and potentially that aerosol could increase the spread of COVID. So if we saw someone and had to use the whistly drill, we had to then, after the patient left and we'd taken off our protective equipment, we had to leave the room and leave that room for a set period of time to allow that droplet spray to settle and then all the surfaces be cleaned. Otherwise, it's okay sort of mopping everything down as we always do, but potentially it could be in the atmosphere. That was what we call fallow time. Now, fallow time then significantly reduced the number of patients that could be seen. So typically, if you're working a 7-hour day in a surgery, each surgery, not the whole practice, but each room could probably only see 7 patients initially. We've had a phased increase in activity as the standard operating procedure has altered. And the standard operating procedure, I think we're on our 6th iteration now, which has significantly increased the number of patients that we can see. Throughout the pandemic, NHS England have supported practices because if we'd gone back to our units of dental activity, and typically a single room would have to do about maybe 35 to 40 units of dental activity. If we were only doing the 1 patient an hour, which we could throughout the pandemic, they'd only say accrue 7 units of dental activity, and financially that was not viable. NHS England have supported the practices in a phased way by saying there was a minimum level of expectation on activity, which I think on there you can see between July, when they reopened face-to-face, and December, it was 20%, then 45%, then 60%, then 65%, then 85%. Now, it has to be acknowledged that when we say 20% of activity, that does not mean that people were sitting around twiddling their thumbs. They were dealing with clinical situations, but it's the number of patients they were actually safely able to see for their staff and for the other patients coming into the practice. We're now at a stage whereby the minimum expectation is 85%, and the reason we're able to do that is that we're now, our standing operating procedure, we're now splitting patients into what we call a respiratory pathway and a non-respiratory pathway. So patients will be asked the questions that we always asked about: are you experiencing continuous cough? Do you have a fever? Any lost sense of taste or smell? Have you been in contact with anyone who's COVID positive? Are you awaiting COVID test? Those who say no to all of those go on our non-respiratory pathway. And if we need to do an aerosol generating procedure, we can use the standard personal protective equipment, and there's no requirement for fallow time. So you can get that patient out of the surgery. The normal infection prevention control procedures apply, things are cleaned down, and the next patient can come in. It's only those who answer yes to any of those questions and may potentially be COVID positive that require then the fallow time. So therefore, we're able to get a far greater number of patients through safely for patients and for staff. In the future, when we'll be back to 100% capacity, I think that depends on what the infection rates continue to be and any future alterations in the standard operating procedure. Anything else I need to cover on there, do you think, Bill?
Thank you, Simon. So what Simon's described really is the challenge that dental practices faced because of the very stringent nationally laid down infection prevention control measures and the nature of dental treatment, which is, you know, you're very close to their respiratory, their airways. I think, just to elaborate on some of the stuff that Simon had said, practices have been funded to continue to open their opening hours, to continue to staff up the clinics in the same way as they've done before. But because of that fallow time and because of having to comply with those infection control measures, it's less patients that they can get through. Inevitably, that's going to impact on access and patients being able to get access. So in recognition of that and in recognition of the fact that there is reduced capacity, and there is still reduced capacity, the National Standard Operating Procedure asks that all practices triage patients and ensure that they prioritise into their available treatment appointments patients based on clinical need and urgency. So anyone who has an urgent dental care need, they are the people that should get prioritised first. Now, there's lots of there is a clinical definition of what is classed as clinically urgent, and often that can be different from what you and I perceive to be urgent. So often, you know, if you have a broken tooth, but you're not necessarily in pain, that's urgent to you. It would be urgent to me. I want that seen to as quickly as possible, but that wouldn't necessarily meet the clinical urgency definition. Because of that limited capacity and because we're having to prioritise based on urgency and those that are at greater risk of oral health, so for example, children are another priority group, that means that they are having to delay or in some instances not able to offer more routine appointments. Unfortunately, that means that, you know, things can it's not ideal. I think, let's be honest and upfront about that. We would love to say that we're going to get back and we're going to be able to address all the backlog and we can get back to offering routine care. But it is going to take us some time to be able to get back to that level of normality. What I'd like to take you through now is some of the things that we've been doing to try and get that access, the number of appointments, the amount of patients that can be seen, to get that increased as quickly as possible within the constraints that we still have to operate within. So we've provided incentives for all practices to prioritise patients who haven't been seen within the last 24 months if you're an adult, the last 12 months if you're a child. That's to supplement the existing sort of in-hours urgent care provision that we have got. I think it's important to note that if you are an adult and you've got healthy teeth and gums, the normal recall, nice recall interval is 24 months. So you may not necessarily need to be seen for a checkup for 24 months. So I think that's another important point that I wanted to make. We have invested in additional clinical triage we've got an integrated 111 dental clinical assessment service, and that's to make sure that patients are triaged as quickly as possible and the ones in greatest need actually get into the appointments that are available, so are prioritised. We've also commissioned some additional time-limited treatment capacity in the out-of-hours period, so particularly over sort of bank holidays and weekends. Over Christmas we prioritised and we had extra capacity there. We've also increased on a recurrent basis the investment into our dental treatment out-of-hours service. So from the 1st of October, a new contract started, which hopefully gives us that recurrent sustainable capacity that we need to meet the urgent dental care needs of our patients going forward. That service is accessed via 111. So what else are we doing to sort of continue to incentivise? We have been out for expressions of interest from any practice who is able to either has the extra surgery capacity or has the workforce to be able to do more. I mentioned that some of the workforce is part-time, so where practices are able to, you know, get the staff to work extra hours, where they've got the extra surgery capacity. We've been out and asked any practices, can they do that? We'll commission some additional activity from you. That is up until the end of March 2022. Again, they have to prioritise into those slots the clinical urgency and high-risk groups as well. We've also, you've probably heard about the additional investment to increase capacity for out-of-hours appointments. So we've been back out to our practices to say, can you do any more in the out-of-hours period? We're busy working through that. So there's an open offer out to all practices across the patch. Anybody who can offer any additional sessions to try and get more patients through, that is an open offer that we're currently working through with our practices. We are continuing to work with all of our dental practices to see how we can support them to just maximise, so making sure that they're up to date on the latest guidance, that they're following the guidance, making sure that they're offering as much capacity as they possibly can. We're also offering practices, so any practice that can deliver more than what the current contracted activity that we commission from them, there is an open offer for them to overperform for this year. Again, it's about trying to get all of that backlog from the times when patients were having to just be remotely triaged. We are trying as quickly as possible to catch up and make sure we see as many patients as possible. We're asking practices to keep short notice cancellation lists and to proactively contact patients. Believe it or not, failure to attend has been a challenge for NHS dentistry pre-Covid. As you can imagine, these appointments are at a premium, and our practices are still faced with patients who appointments are booked, but for whatever reason, they don't turn up, they don't necessarily cancel the appointment, for absolutely very good reasons, but obviously that means that we can't fill that slot. So it's about the practices gearing themselves up to try and keep those lists, to try and offer appointments to bring people in where somebody sort of cancels at short notice. That is a challenge and it's not always possible, but hopefully that will help us to get more patients through the door. I also mentioned about recruitment and retention. Obviously, the rurality of Northumberland, it is a challenge in terms of dentists and getting more dentists in. We're working with our health education colleagues and their delivery partners to try and encourage and support the development of any new initiatives or any opportunities that we can get to improve not just the recruitment of new dentists in, and to streamline the processes for doing that, but also in terms of how do we retain the dentists that we've got. We're also working with the national team on what can be done from a national perspective to try and make the NHS contract, the NHS service, an attractive proposition that dentists want to stay within the NHS and new dentists want to come in. I'd just like to finish by just summarising some key points. So all dental practices are open. They're open, the same opening hours, the same staffing, but they are still operating at reduced capacity. You know, I would love to tell you that things are back to normal and they can offer the whole range of what they did before, but that's not where we're currently at. We're trying to get there as quickly as possible, but that's not where we're currently at. So that means that they do have to continue to triage patients. So they need to make sure that their appointments go to those in the greatest need. Unfortunately, that still does mean a delay for patients who require more routine treatment and typically sort of routine checkups. Each practice, so I mentioned that, you know, different practices can have different demands. So each practice is risk managing their resumption. So you could get a scenario where you could phone up a practice for something which is less urgent and they may have capacity to see you because it depends on the demand that they've had into the practice on that day during that week, where some other practices might not be able to offer you that because they have been inundated with patients that would hit that sort of more high needs category. In terms of the current position, is obviously we've got a minimum expectation on practices to deliver 85%. We're signalling to practices that we would hope that they could get back to 100% from April, but I think, you know, we do need to, our clinical colleagues are keeping all of the clinical protocols, the standard operating procedures, they're all being sort of kept up to date, and it'll depend on the further easing of those in terms of how quickly we can resume back to what was the pre-COVID normality. And to be fair, and let me be upfront, you know, access was could be a challenge pre-COVID in some areas, absolutely, in terms of the legacy commissioning arrangements, but we are committed to try and do everything we possibly can to move that forward. I think what I'm trying to describe is that the dental teams are working really hard to try and see as many patients as they possibly can within all of those stringent guidance and regulations that they have to work with. Children are a priority group, and I just really wanted to finish by saying, and everybody should be aware, that NHS treatment for children is free, and we would encourage children to be, you know, brought to the practice as early as possible. But we understand the access challenges that are out there at the moment. I'll stop there and happy to answer any questions.
Thank you both, to you both for such a very clear explanation. Thank you. Questions? Councillor Hill?
Thank you. I agree. I thought that was really helpful and really clear and honest, because it is a major problem. I've had many residents who've called up in agony, and they can't get a dent, they just can't, and then they maybe think they'll try to get an antibiotic from the GP, and then they're told go to the dentist. So there's, and then you worry, thinking, God, are we going to get back to some sort of Victorian age? You're reading about people doing DIY equipment, so it's really helpful you explaining the impact of COVID, and looking to get back to some resemblance of normality. Just a couple of quick questions, if I may. First of all, could you tell, it was really interesting what you said about registration, because in my experience, never experience, you're registered, you think you're registered at a dentist, they've got your record, and then they used to contact you and have the appointment every 6 months. And then you're hearing about people struggling to register for a dentist appointment. And you're thinking, well, I'm glad I've got an NHS dent. I've been registered there for years. So if you could just tell us a little bit more about that, because that's interesting. Also, one thing that I've picked up on recently, it was always very clear, the charging, you know, the 3 bands of charging. Now, recently I've had residents say, I had 1 course of treatment and I was to go back, but they made me pay for that, or something. There seems to be more concerns about the charging. I've just looked on the website and it just seems, it says it always was, there was 3 bandings. And just the final question, in terms of recruitment and retention, is it the case the amount of people that are training, qualifying as dentists, has that gone down? Is my first question. And the second question, because there's a shortage of dentists and it's such a stressful job and it's lucrative, I imagine dentists retire early as well. So, or is there earlier retirement and fewer qualification? People qualifying. That's my final question. A few there.
Can I start and then you can jump in? Yeah. So in terms of the registration, I think you've hit on a challenge for us, because I think there's this perception that everybody needs to go to the dentist for a checkup every 6 months. Now, the recall interval for any patient should be based on your oral health and based on an individual assessment of your needs. So dental practices do tend to have a cohort of patients that they look after, not registered. So they should know what your recall interval should be. And under normal circumstances, they would be recalling patients based on that to bring you back in for your checkup. Obviously, COVID has changed that, and they're having to prioritise based on clinical need and urgency. So I think gone are the days where patients can just keep coming back for a routine appointment. It does have to be based on that clinical need, particularly where we've got reduced capacity.
think some people are concerned, though, that there's been some stories of people going back and saying, oh, you're no longer with us. So, and people thinking, well, okay, I haven't had my regular appointments, but if something goes wrong, at least I'll be able to go get a dentist. And then I think people feel quite insecure that if that's the case now, and you're hearing stories of people saying, you're no longer registered with us, and we've got no more capacity, and you haven't seen you for 2 years, so you're off.
And I've equally heard that. And what we're doing is we're reinforcing with our practices, because obviously during COVID, there is a likelihood that you may not have been back for 2 years. And there shouldn't be using that as a reason to remove anybody, even though there's no registration. If you ring a dental practice, if you've got a dental problem, I think one thing that I should reinforce, because I've reinforced in other areas, if you've got a dental problem, when you phone the practice, say what that dental problem is up front. Because at the minute, if you just say that you want to register or you want to book a checkup, there's a high probability that the practice are going to say, well, I'm sorry, we can't offer you an appointment at the moment. So I think I just really want to reinforce that while I had the opportunity. So I think it is challenging. You shouldn't get removed from anybody's list because of that. Certainly, we will reinforce that with our practices. In terms of the charging, you often get patients who come in and have very high dental needs. Now, normally, you would have an assessment and the dentist would determine what your full treatment needs are. But if you have got significant oral health, there is a clarification that's been brought out from the Chief Dental Officer for NHS England that some of that treatment could be staged. Now, some of that is for clinical reasons in terms of, not having to necessarily do everything all in one go. And that sometimes results in patients having to pay an extra charge. And I'm probably going to hand over to Si, because he could probably explain it much better from a clinical perspective.
Essentially what we call it, the initial, if you walked in, we may have a patient presenting, they come in and they've chipped a tooth, and it's very simple. You've chipped a tooth. You might not have been for 5 years, but your oral health is very good. We'll repair that for you. Jobs are good enough, you go. And looking at you haven't been for 5 years. We'll see you in 2 years' time. Gone are the 6-month checkups. We risk assess it and say, you haven't been in for 5 years. You've got one chipped tooth. You're safe for 2 years. Equally, someone else comes in and they have 15 decayed teeth. So we look at that and say, okay, what are we going to do here? 15 decayed teeth. They don't brush the teeth very well. We then say, okay, what we'll do here is, first of all, let's treat the cause. Let's get you cleaning your mouth better. Let's chat to you about your diet. Are you sort of sitting there at work with a pack of Polos and a can of Coke and shoveling all that in, which, whatever we do, you're going to continue to get decay. We'll do that, and then we'll say, okay, let's sort of treat the basic decay and sort of anything that's likely to sort of cause infection, to cause pain. We'll do that. And then say, right, we're then going to review you in 6 months' time and see, one, have you stopped eating 5 packs of Polos a day and drinking 4 cans of Coke? Yeah? Are you brushing your teeth like we told you to? And if you then see them and say, actually, things are improved. Okay, now, those teeth there, we can sort of repair those in the longer term by putting a crown on or something like that. You don't go straight for the top of the range treatment when someone is very likely or possibly is not going to respond to the advice that you're giving them. So that's why we phase treatment. It's about treating the basics, trying to improve the health, and that's the thing there. It's not just filling teeth, it's trying to get them to improve their health. And it's okay, dentists doing treatment, but it's a partnership. Unless the patients buy in and they listen to the advice and modify their behaviours, because dental disease is completely preventable. If we don't have too much sugar, if we don't have too many fizzy drinks, if we have a good diet and we brush our teeth, we've got a lot of young people nowadays who have no fillings in their teeth, no holes, because they've been brought up, their parents have been bringing them. Of course, that's in certain areas. Unfortunately, in other areas, we have high dental needs because those people, different socio-economic group, They don't respond to the advice, and consequently, they're less likely to improve their oral health and are more likely to have long-term dental disease. So the phasing of the treatment is about treating the initial presentation, trying to stabilise it to prevent future deterioration. And then, if things stay stable, then going on to a second phase. Does that make sense? Yeah?
I suppose from a cynical point of view, you could say some dentists might have said, somebody's had a lot of treatment and they've only had to spend 60 quid. We'll get more money if we phase it out. So you can see probably where there's probably a very good point why it's done, as you've explained, but there's probably a bit of lobbying from the industry as well.
So if I can just explain, the 60 quid that the patient pays, the dentist doesn't get. You're going to say, surely they do. That comes off, the dentists are paid a contract value. So, I don't know, let's say it's £10,000 for the surgery for the month. So, by the way, it's not the dentist that's paid, it's the practice, and that then pays for the equipment, the heating, the lighting, the dental nurse, the receptionist, etc. If you go in and spend your £60 on patient charges, they'll get the £10,000 that month minus your £60. They don't get extra. Does that make sense? Yeah. So they get the same whether the patient pays or they don't pay. So if you get an exempt patient in, you might say, oh, they don't take that patient on because they don't pay dental charges. The practice gets the same whether the patient pays the dental charge or not. Yeah, yeah. Again, that's a common misconception. They don't take that patient on because they're exempt from patient charges. It's completely cost neutral for the practice.
Si, do you want to pick up the recruitment and retention?
Oh, sorry, recruitment and retention. Yes, so recruitment and retention. So if we look at me, grey of chops, I went to dental school in 1983 and I graduated in 1988. In my year, I think it was about 66% male, 33% female. That was starting in 1983. By the time I graduated in 1988, their intake was 50% male, 50% female. If we look at now, it's flipped and the predominance is female applicants and fewer male applicants. Now, if we look at my practicing career, I worked 5 days a week, pretty much all the way through. I was a man. My wife, though, who isn't a dentist, if we'd looked at her, if she was a dentist, she would have a career break to have children. And then, having had the children, may not go back to work full time, may say, I'll tell you what, that doesn't fit in with my lifestyle. So we have a shift in the profile of the workforce. So part of it is the fact we've got more females who may have a career break for family reasons. Equally, though, we find that whether it's male or female, there are very few people who wanted to work the way I did, which when I was a very young guy, I'd work 8:30 till 5:30. I'd also work on a Saturday morning. The constraints in those days were fewer. You were able to do that, and the pressure was probably less. There's a lot more pressure on the workforce, and consequently, people will often say, a little bit like our GP colleagues there, they may say, well, I'll tell you what, I will work 3 long days a week, I'll have two days off, or I'll have 3 long days, and they may have a separate interest that they do. So consequently, if we say how many dentists do we have in the country, we have a lot. How many full-time equivalents do we have? We have far, far fewer. If we look back a few years, when I was at dental school, I was coming into my final year and we were told by the then professor of children's dentistry that they were very likely to produce a vaccine which would vaccinate people against dental decay. Which means that we'd be able to sit there, say hello, have a chat about your holidays, have a little flick round and say, lovely chatting to you, we'll see you in 6 months as it was then, 2 years as it is now, or a year, depending. it was found that if you vaccinated against the bacteria that predominantly produce dental decay, which is Streptococcus mutans, then you found that Strep viridans or any of the other bacteria jumped in and they caused dental decay as well. So that didn't work. The knock-on effect was they looked and said people's oral health is improving. They did at one stage close some dental hospitals. I think Dundee might have closed a lot of years ago, probably before you came into dentistry. However, there's national work looking at the number of dentists that we have, or also looking at the dental workforce. We're talking there about nurse practitioners. I fell off my bike and broke my arm, went to the RVI, and I had this very nice person came up and said, I'm a nurse practitioner. You can wait 5 hours to see the doctor there, or I can have a look and we can probably have you in an hour and a half. I was very happy with that service. She was very professional, very personable. Yes, I broke my arm. Come back tomorrow and we'll deal with you then. So within dentistry, we don't just have dentists, we have dental hygienists, we have dental therapists, we have extended duty dental nurses, we have oral health practitioners. Now, under our current contract, it's difficult for those to work within our current dental contract. However, we're going through a period of what we call dental system reform, where they're looking at the workforce we have and how best we can utilise them. But for that to happen, we're going to have to undergo some changes in dental regulations and changes in dental contracting to enable those people to work to their full scope of practice. There's some very good dental professionals out there who can deal with most of the dental conditions, but at present we're a little bit hamstrung by our contract, which was out in 2006, and that contract did not reflect the dental workforce that we have now.
Could I just come in and sort of summarise? So I think one of your questions was about, are we training less dentists now? No, I don't believe we are training less dentists. I think it's a bit around what Si was saying about dentists are no longer working full-time. You know, it's not necessarily just about women and men. Everybody is choosing now to work more flexibly, to work part-time. Some of the, dare I say it, sorry, some of the older school dentists are coming up to that time when they are wanting to retire. So I think it is a challenge, but there is a lot of work going on nationally, and there's a lot of work going on regionally to try and make sure that we retain as much of the workforce as we've currently got, that we try and open that up in terms of the skill mix, but that we also try and bring in new dentists in an area, and particularly focusing on areas of high need, like Northumberland, where historically necessarily dentists haven't, you know, a lot of the dentists want to congregate around the dental schools, want to go to the more sort of the centres, the more cities. It's always a challenge when it's a more rural area, and that's reflected in some of our commissioning. So some of our recent commissioning around contracts that we've put out, we're actually paying an extra premium for those contracts so that they can try and recruit the workforce that they need. So there's lots of work going on to try and address what is a sort of a barrier to us being able to maximise access.
And absolutely, the workforce and retention is being looked at constantly. In fact, Pauline and I are at a meeting on Thursday specifically looking at that. So it's not just, yes, the paying lip service. One of my functions is to be, initially was to be a critical friend to NHS England and challenge them from a clinical point of view. We don't do that. We basically all sit around the table and work together and think, how can we best do this? What are our challenges locally and how can we best address it? So you know, that's actually being looked at present.
Thank you very much. And you had quite a few questions. Were they all answered there? All answered, yeah. Thank you. Thank you. Councillor Vilchek.
Thanks, Chair. Just a few points. I just wanted to hear Pauline's thoughts on the fact that my friend recently tried 8 different practices across Blythe and Cromlerton, only to find out that they weren't taking on NHS patients. She ended up paying £40 up front for a checkup. And I know several friends going further afield from the Blythe Cromlechton area, ending up further afield to places such as Killingworth, which is quite a trek to see a dentist. My second point is the fact that I've got concerns about private practices taking on NHS contracts, and I find myself, and it's happened to another family member, where the dentists are pushing private work on NHS patients. So I've had it, but also my husband's grandmother, not in this authority, in a different authority. My husband's grandmother is an NHS patient, and the dentist was pushing private work for her denture. And it wasn't until my husband had to correspond with the dentist, and the dentist realised my husband's a dental technician, that dentist backed down, which is quite worrying. And my third point is to go back on recruitment and retention. It was obviously you mentioned the dental nurses, but also the dental technicians. You know, we've got dental technicians, and there's fewer getting trained up and whatnot, because, you know, dental technicians work with cancer causing chemicals, work in poor conditions, get paid a pittance. Simon referred to Kovid. The General Dental Council didn't even give dental technicians advice with regards during the Covid pandemic. You know, it was all the guidance was for dentists. You know, the dental technicians didn't get a look in, and obviously without dental technicians you wouldn't have working dentists. So I think that, you know, going forward nationally is going to be a big concern really, because, you know, if you haven't got dental technicians training up, and if they're leaving the profession, and they're not being looked after, you know, it's who's going to be making the dentures and whatnot. Thank you.
So I'm really sorry to hear of the experience that you've just outlined. I think it comes back to some of the messages that hopefully I've given across today, which is depending on what the clinical need is, and I don't know the circumstances of your friend, but based on what the clinical need is, because of that reduced capacity, practices are having to triage. So I think I mentioned that if you phoned a practice up and you just asked for a routine appointment and a checkup, the chances are they're not going to be in a position to be able to offer that, probably within the timescale that you would want it, because I'm sure nobody would disagree that somebody in pain and somebody with sort of eye oral health needs to take priority. Unfortunately, that's the situation that we're in. We're trying to get back to some sort of normality where more routine appointments will become available. So I think that is going to continue to be a challenge for a little while longer, but hopefully what I've described will give you the assurance that we are trying to get back to that normality as quickly as we can. Your concerns about the private practice, I think I'm disappointed to hear that any dentist would push private. I think it's right that they offer patients options. I mentioned these are independent contractors, so if they're not able to meet whatever your dental need is, and they can offer that privately because they have that separate part of their business, then I think it's right that they offer. But no patient should feel that they have to take that option. It should be personal choice. If anyone has an urgent dental care need and you are struggling, you've rang lots of practices and they're not able to fit you in during the day, ring 111, because we do commission from for dental practices, we do commission some urgent access slots. Now 111, you will get triaged, and if your need meets the definition of a clinical urgency, you will get booked into one of these slots, either the in-hours or the out-of-hours treatment centre. So there shouldn't be anybody who has an urgent dental care need that is not able to access. But it does come back to what's urgent to me and then what is clinically urgent. So it may be that what's urgent to you, you may have to wait a little bit longer for an appointment, but you are trying to resume things as quickly as possible. Your recruitment and retention thing, absolutely right. You know, the focus is not just on dentists. If we are going to treat as many people as possible, we need to improve the skill mix. So dental therapists, dental nurses, technicians, they all play a key part. There are some regulatory challenges that Si touched upon, which I think makes it challenging but not impossible. So we have some practices that have got very good skill mix and use their therapists to best advantage. And some of the dental contract reform work is how can we move further faster in terms of getting that skill mix approach so that patients are seen. Because a dental therapist, under their scope of practice, there's a lot that a dentist currently does that can be done by them, but at the moment under an NHS contract they can't do the initial treatment planning. They can do the work under prescription of a dentist, but hopefully things like that will start to change. And you mentioned about the guidance from the GDC, and you mentioned about the guidance into technicians. So throughout the COVID pandemic, there has been national standard operating procedures that have applied across the whole of the dental system. All of that has been circulated to our dental providers. Now, they're all independent businesses, so they employ their staff, and they've all got different arrangements. And you're right, the rates of pay in terms of what they get paid will be determined by that particular dentist. So we pay a contract value. All of the guidance around what you should do clinically, that's all standardised, that should be available. So all I would say is ask your friend to get in touch with the provider that she works for, because that guidance, that support is there, and you should be accessing that through that provider.
Thank you. Councillor Hunter.
Yes, thank you. Again, it's more onto the recruitment. It's nice to hear what Simon's saying, that they're trying to change the contract so that it gives you more capacity. Up in the rural north, we usually have a problem recruiting for many different professions, and dentistry is no different. We've got one of the practices up in the Berwick area who has had 2 dentists that's retired recently. And patients are getting told they won't get appointments until they recruit a new dentist. They will pick them up if there's an emergency, but until then, you know, and it's just a case of if you need a fill-in, if you've got a broken tooth, unless you're in pain, no chance, you know. And if it's going to be a year, 2 year, that's it, you know. And I think it's that looking at how we can actually do it. I know they're not in pain, but they're trying to think, well, when am I ever going to get a treatment? They're not just looking for a checkup. And again, they probably don't realise they could try different practices, but it's all sort of the same in the north, because they know that dentist's got their records, so that they've got the history. But I think it's that fact that they can't get any appointments unless they're in pain.
I think absolutely, you know, you need to have the workforce there to be able to offer the appointments. And certainly we're in discussions with the providers in Berwick, so I'm aware that there are some challenges that have just emerged. We're trying to look at, is there anything we can do under the contract in terms of any flexible commissioning? Is there anything we can do in terms of signposting? So some of the work that we have done in the past is we have funded adverts to try and attract dentists into the area. We've offered flexibility around the contracts in terms of sort of training support to try and get the dentists in the areas of need. So our dental practices are really good at coming to us and telling us what the challenges are. That gives us the opportunity to open that dialogue, to see what the art of the possible is. Unfortunately, these problems don't get fixed overnight, and it inevitably has the type of impact that you're describing. But we are trying, you know, every avenue to try and make sure that, you know, where we're losing dentists, we can try and get more in to replace that capacity.
Thank you, Councillor Nisbet.
You were on about the 111 service, if they were in real pain. I had a resident that recently did that, and they did get in to see because they had very, very bad teeth. So when they got in, they did the triage, and they said they gave them some antibiotics, and then it cost £75. But then they were offered to have their teeth taken out, which would cost £200 at the dentist, or go to the RVI to be put on a waiting list, which I think is quite wrong, really. And the other question, the other one was, just recently, there's been 2 or 3 of my residents have more or less been booted out of the dentists in Blythe. Why, I don't know, but they got a letter to say that they were no longer on the register.
I'm a little bit surprised around some of the costs that you were quoting, because the dental charges are set nationally, so that's not something regionally that we look at. So if it's NHS care, and I think that's the important thing, it sounds like perhaps there may have been given some private treatment, but if it's NHS care, it certainly shouldn't be those types of figures. If they require dentures, that the dental charge for that is over £200, and unfortunately, as I say, that is set nationally. The £75 for antibiotics, I sort of don't recognise that as any sort of charge, so I'm a little bit puzzled by that. I suppose the advice that I would give is that, you know, when you're accessing these services, make sure that you're accessing as an NHS patient. If you've got any queries about what you're being charged, challenge the practice, ask for the explanation. They should be able to justify what they are charging you. NHS 111 should be triaging you into NHS care. So I think there is an expectation that that's what you should receive. If you're receiving something different and they are wanting to charge you something outside of the NHS dental charges, and I'm happy to share information leaflets. I know we've done it through Health Watch in terms of just educating people about what those dental charges are and what the criteria is. I think the more we can get out of there, but I would certainly say to anybody who is not clear about whether they're getting NHS treatment or they've got a query on the charges, please, you know, raise that with the practice. I would be happy to pick up outside of this meeting the concerns that you've got around patients being booted out, I think was the term was the term that you used.
The person himself, he says, I've been booted out of being a dentist.
Yeah.
Because he hadn't been for a while. But when that happened, somebody else came and said, well, I've got booted out as well.
Yeah.
So it sort of escalated where there was a few people at the end of the day have been told that they're not in the practice anymore.
And
whether it's because they haven't been for a while, but I mean, you've more or less explained that, they haven't been for a while or not, but it's just recently that's happened.
I think sometimes
it's a indelible practice.
Yeah, I think sometimes when I sort of hear this, sometimes when you look into it, sometimes it's a miscommunication, which shouldn't happen, because I think, you know, we all need to be clear. Again, it depends on what they're trying to access the practice for. So their definition of being booted out may be that they haven't been able to go back for their routine checkup. So without sort of understanding the detail, it's hard to generalise. But as a general rule, that shouldn't be, you know, practices shouldn't be sent to somebody where you haven't been to see me for over 2 years, therefore I'm not going to see you. You have an expectation, if you have a dental problem, that they should triage that dental problem and they should offer you advice or treatment depending on what your treatment needs are.
Thanks for that.
Councillor Dodd.
Yeah, the question's been answered. The question's been answered about retention and recruitment, because it's been mentioned a lot of times, and it's not new. We had this problem years and years ago, and we even had a campaign going called Discover Our Land. Now, I do not know what that cost, or if there's anything that went with it, because the whole point of that was to try and attract not just dentists, etc., but it was doctors, professionals, etc., to Northumberland. I wondered if it might be worth us, as a scrutiny committee, looking into that to see if it did do any good, or if it continues to do any good. Because I know it would cost something, but I don't know what, how, or where. Thank you.
I'm not sure that was the Discover Our Lands campaign, I think, but there was a campaign. I don't know if Kath McAvoy, are you? We're talking about the campaign they had to recruit doctors, dentists, etc. to Northumberland, well, professionals, by outlining the beauties of living in Northumberland. It might have been the Discover Our Land campaign, but I have a feeling there was actually another one that's called something else.
Now you're testing my brain cells. I can't remember, but we'll find out.
Yeah. I think what Councillor Dodd's asking is can we look to see how successful that was?
Yeah.
Yeah, thank you.
I do remember that Councillor Dodd's right. There was.
Sorry. I do remember that Councillor Dodd was right. There was an awful lot of work done. This has not been a new problem. There's been some, issues, and I remember some years ago I was talking about some particular areas where dentistry was a particular challenge, and we were concerned because of the numbers of children, etc., living in that area. And there was a campaign, but I can't remember which campaign it was. I think there's been a number, actually, to be fair, run by ourselves and by others in this area. So
Just may not have worked, and I wonder, what was the cost? Do we repeat that exercise? Because it's not just dentistry, it's all across the board. So it was just a question, maybe some future work or etc.
Thank you. I think it was there was a North East campaign as well. Derry, I think you had a question as well.
Yeah, it was just a comment really. Just to say, I think the experiences you've heard this afternoon, as you know, from Health Watches, not just in Northumberland but across the region, have been similar. But certainly this issue of communication is a really big one. So people being booted off, as Councillor Nesbitt said, of just ringing up and saying, well, I've been told I can't attend anymore. And I think one of the things that worries us about that is that when they've then gone back to the dentist surgery, to the practice, to ask more questions, it hasn't always been the friendliest responses. And where they feel that they've not been perhaps treated fairly and they've wanted to put in a complaint, it's been quite difficult to find the complaints procedure and to actually how that goes. And I know because when I've been talking to people on the phone several times myself, I've actually gone and looked at the practice to see if I could find the complaints procedure, and I couldn't. So I think this whole issue about communication is really, really important, because people are going to feel aggrieved if they can't in the first place, but they're really going to feel aggrieved if they then don't feel they're getting a fair hearing.
So every practice should have their complaints procedure on the wall. So when I had my practice, and you said, well, where is it? On there. It should be there. And the complaints procedure should be simple and easy to follow. The whole point about it is to get early resolution. If you have an issue, the sooner you talk to me and the sooner we talk about it, the better you feel. And quite often it will be, you don't have a big problem, you just want to make a comment. And if I listen to you, often the fact I've listened to you and we've had a chat about it, you say, that's great, we don't need to go any further, I'm happy with that.
I know that's the theory of dispute resolution.
But it should be on the wall, and it should, and in fact when the CQC go round, the CQC straight away they'll walk round with the clipboard, they'll sit in the waiting room and they'll look and see what's there, and they should be able to see the complaints procedure.
But of course in the last 2 years it's not been a case of being on the wall, it's on the website, and yes, we all know that with websites best practice is one click, and certainly one factor's in my mind that I'm thinking of, I did not find it within half a dozen clicks.
Right.
So I think that you're right, absolutely, that's the theory, but it's actually getting it front and centre.
I think, Jerry, we would be really wanting to work with you in terms of what communication we can get out of there, because we would always encourage a patient to go to the dental practice first to try and resolve whatever their concern, whatever their complaint is. But there's also the NHS Customer Contact Centre that can also be accessed for complaints. So I think there's a couple of avenues. So certainly more than happy to have further conversations about what messages we can get out there and how we can support that. And I'm sure our dental practices would be more than happy to
Absolutely. I mean, I think
this
it's one of the system issues that we recognised when we started the work with the Mythbuster as well. But I think, you know, obviously for us, we would signpost to the contact centre, to the, you know, to the practice first, as in any complaints procedure. Mm-hmm. But it just seemed to be there were barriers in people's way.
Thank you. Well, thank you both for, as I said before, a very clear presentation and answering some quite complicated questions. So thank you very much for coming. Yeah, thank you. I'm going to move on now to the Health and Wellbeing Scrutiny work programme. Chris, do you want to just take us through it? I think it's the easiest way.
Thanks, Chair. I hadn't really planned to say much about the work programme because the one that's been included with the agenda is, by now, it's about a month out of date, so it's not particularly the most accurate. So what I was going to propose is, after the meeting, I'll send members the most updated version, and if anybody's got any questions, then I'm more than happy to discuss it with them. At the next meeting, at the 1st of March, I'll also include a draft version of next year's work programme, so May to April 23, and we can have a discussion then about what's included on that work programme. I think Councillor Dodd's point about the Discover Our Land campaign, I'll try and find out what the recruitment campaign was and see if we can bring something back. And yeah, and that's it really, I think.
Thank you. Well, next item's then will be Tuesday the 1st of March, which, because of the delayed programme last time, is very shortly. And that's it. So thank you all for coming. Thanks very much and safe journey home. Can we end the live stream?